Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. And good afternoon, everybody. So our subspecialty lecture today will be about diagnostics in glaucoma. We will have an overview of optic nerve head OCT, visual field, and UBM as well. Now, before we go over the optic nerve head OCT, we need to understand what does the optic nerve head evaluation constitute? What does it consist of? So whenever you want to evaluate the optic nerve head, you need to understand certain components. You need to know that you have a neuroretinal rim. You need to know that you have a cup that you need to measure and assess. You have the lamina cribrosa that you can sometimes assess or comment on its depth and exposed pores. And you have the scleral ring, peripapillary atrophy, and nerve fiber layer. So that's what we can see as clinicians. But we actually never know what's happening within the optic nerve head. We actually don't know what's happening before we develop glaucoma and after we develop glaucoma. And that's why we needed an equipment or a machine to tell us what's happening there. And therefore, the evolution of OCT took place, and it's now one of the most important diagnostic utilities that we have in glaucoma practice. The optic nerve head complex evaluation, as we mentioned, depends on assessing the disc margin and the disc diameter and take it there to the neuroretinal rim assessment, the cup to disc ratio, the disc diameter, and the peripapillary atrophy existence and area, nerve fiber layer defect, and the presence of optic disc hemorrhages. Before we go within the OCT of the optic nerve head, we need to know that we have certain optic nerve head phenotypes that all of you are familiar with. We have focal, diffuse, and sclerotic, and these optic nerve head glaucomatous phenotypes are important because we know that focal optic nerve head damage is the most rapidly progressive in visual field changes, followed by diffuse, and then followed lastly by the sclerotic optic nerve head phenotype. So if you have a focal optic nerve head damage, that's the patient in which you need to pay more attention for because he's the candidate for the most rapid progressive visual field changes. Now, OCT in general enabled clinicians to perform in vivo histological analysis of the optic nerve head. We are familiar now that we have something called Bruch's membrane opening. We have prelaminar tissue, we have lamina cribrosa, we have a border tissue of variable orientations and positions and shapes, and we have internal limiting membrane. Now, while doing the OCT of the optic nerve head, we had an infrared image of the optic nerve head, and we had the real-time disc photo of the optic nerve head. So what scientists have done and researchers have done who are interested in glaucoma and OCT, that they were wondering, does what we see in the OCT match actually what we see in real-time exam of our patient or not? So what they have done simply is that they went and they segmented the real-time disc margin, and they segmented the neuroretinal rim, and they segmented as well on the IR image the disc margin and neuroretinal rim, and they overlaid it on the OCT or the B scan constituting the OCT of the optic nerve head. So that's the projection of the clinical disc margin that we have plotted on the optic nerve head. So that's the edge of the optic nerve. And this green spot represents the clinical disc margin that we have seen. Where does it lay on the B scan derived from the OCT? So you can see that here the clinical disc margin is coming behind or lagging behind the true neuroretinal rim opening, which is the Bruch's membrane opening here. The same thing apply, but on the other hand, in certain area, the clinical disc margin lay exactly over the opening of the Bruch's membrane. So why the opening of Bruch's membrane is very important? Because if we see here, the opening of the Bruch's membrane constitutes the true neuroretinal canal, or the space in which the axons pass to constitute the optic nerve head. Now, we segmented the Bruch's membrane opening, and then we transmitted this segmentation on the real-time disc photo that we have taken from the patient. So we had a mismatch. in the previous scan, as you can see here. So that's the clinical disc margin. And that is the true Brooks membrane opening based disc margin. So it tells us that instead of estimating that we have a large neuroretinal rim remaining based on our clinical exam, in reality, depending on this segmentation, it seems that the neuroretinal rim remaining is actually smaller. So again, if we assess the neuroretinal rim, we have a smaller rim here. While if we assess now on the disc margin, the clinical disc margin, the neuroretinal rim seems to be larger. There is another example here as well. So that's the clinical disc margin. And that's the Brooks membrane detected disc margin. And you can see that there is a big discrepancy in the inferior part, but not in the temporal part. So if we have a discrepancy between the Brooks membrane opening and the true clinical disc margin, it doesn't mean that this discrepancy will be all over the optic nerve head. No. It might exist sometimes inferiorly. It might exist sometimes temporally, as what we are having in these previous two examples. We know that most of the hits in glaucoma that are of significance and important for us are those that are happening in the superior and inferior pole. So if we have an underestimation of the true residual neuroretinal rim or overestimation of the true residual neuroretinal rim, that will create an issue for us in our clinical assessment of patients who are having glaucomatous optic nerve head damage. Again, the OCT enabled us to know what's happening exactly in the optic nerve head. So what type of Brooks or border tissue configuration that we are having here? We have an internal oblique border tissue, and you can see that the Brooks membrane is overhanging here to some extent. Another internal oblique Brooks membrane, and we have significant Brooks membrane extension here. We have an external oblique border tissue, and we have non-oblique border tissue. The awareness of having different types of Brooks membrane configurations and realizing that we have internal oblique Brooks membrane internal oblique border tissue with overhanging Brooks membrane, it actually tells us that sometimes we are actually over or underestimating the residual neuroretinal rim. Now let's go for some clinical examples to check how does the OCT can help us in our clinical practice and what's the difference in the diagnostic capabilities of the nerve fiber layer and the Brooks membrane opening based optic nerve head diameter, or making it simply the minimum rim width. So in this example, we have 50-year-old gentleman who's myope of -4.5. He's having primary open-angle glaucoma on prostaglandin analog, visual acuity of 20/80, and the IOP is 16. And he's complaining of drop vision. So when you look at his optic nerve head phenotype here, you could argue that this patient is actually having a focal optic nerve head damage, while the inferior rim is almost lost. And you will look, when you look at the visual field here, you will have a matching visual field change. So inferior pole loss of fibers with a corresponding superior visual field defect. So when we look at the patient's nerve fiber layer analysis, we can see that he's having dropped nerve fiber layer thickness in the inferior pole, which is corresponding to the clinical correlation that we had. So we have definite nerve fiber layer changes of the OCT. But does such changes match the visual field changes that we showed you earlier? When we go now for the minimum rim width or the Brooks membrane opening based OCT parameter, we can see that the patient is having much more significant drop in the rim. So the rim is very narrow using the OCT optic nerve head compared with the RNFL. So we can appreciate the difference here between these two slides. So that's the clinical appearance, and that's the loss of the inferior rim, correlating with dense superior scotoma and that's the RNFL changes, and we have far significant changes in the BMO minimum rim width OCT results. Another example, we have a 45 years old lady with primary penangle glaucoma and prostaglandin analogs again, visual acuity of 20/40 and a pressure of 14. So that's her her disc photo in 2008. And that's the disc photo in 2013. You can look that there is a disc hemorrhage here compared with the previous slide. And that's the 2015 disc photo of the same patient, and you have a nerve fiber layer defect correlating to the area of the disc hemorrhage that she developed 2 years earlier. And then after that, she started to develop thinning, which is corresponding to the same area. So that's a patient with normal tension glaucoma. So while the minimum rim width helped us in the last case, we will try again and check if it can give us early detection or not. So that's the minimum rim width, and it seems to be normal in 2012. And we will show you here the real-time image. Unfortunately, it's not working. So, in 2008, small disc hemorrhage overlooked, intact nerve fiber layer. 2012, nerve fiber layer defect, disc hemorrhage. And you can see on the IR image, the nerve fiber layer defect. So there is clinical evidence of glaucomatous disc changes. And when we look on the other hand, on the RNFL, it showed us a corresponding RNFL changes, while in the minimum rim width, we could not have, or we could not detect the changes compared with the RNFL. So what does this tell us? What's the message that we are trying to take from these two cases? Structural changes, yes, they do precede functional changes in glaucoma. RNFL diagnostic capability proven to be lower than the minimum rim width diagnostic capability. However, it does not apply to all categories of glaucoma, especially in patients with normal tension glaucoma. So you might elect to choose both diagnostic utilities, the RNFL and the minimum rim width as well. Again, to the same patient, and we are showing you now the two slides to compare. So that's the RNFL again, inferiorly, and we have then the MRW superiorly. And when you look at the visual field, it gives you also a corresponding visual field changes. So that's the 2015 MRW OCT, and that's the 2015 RNFL OCT, which is showing you a far progressive optic nerve head damage compared with the one that we showed you at 2012. So this is the progression, 2012 compared with 2015. And this is the disc photo from 2008 till 2016. And you can look and check that we have disc hemorrhage superiorly, followed by nerve fiber layer defect. And at 2016, the thickness of the neuroretinal rim superiorly at 1 o'clock area decreased significantly compared with the 2008. So that's the difference between both optic nerve head photos. A third example showing us a 28 years old lady with primary penangle glaucoma on maximum medication with a visual acuity of 20/60 and a pressure of 26 was referred for surgical intervention. So that's a patient who is having unilateral glaucoma, normal optic nerve head on the other eye. That's the corresponding visual field changes. And that's the OCT printout that you will get in your clinic, showing the changes in the minimum rim and the residual neuroretinal rim, taking the distance from the ILM to the Brooks membrane opening. If you look at the circle that we put superiorly, you can see that there is significant loss of the rim. Inferiorly as well, there is significant loss of the rim. But if you look at this area, you will see that there is still some good residual rim. Again, we are comparing both eyes, and both the minimum rim width and the RNFL are showing changes, but the magnitude of change in the optic nerve head using the minimum rim width is much more significant compared with the RNFL. So again, this is a patient who is having a high pressure in the 20s and having much more significant MRW-based changes compared with the RNFL. So again, minimum rim width parameters can be used in patients who are having glaucoma. In normal tension glaucoma, you might elect to add RNFL analysis with it as well, because it might have more diagnostic capability compared with the minimum rim width. Now, we will go over the other topic in our subspecialty lecture today, which is the visual field. The Humphrey visual field analyzer is one of the most important utilities that we used to use and we are still using, and its concept will stay for some time. The reason is that it will give you, a prediction of what will happen in the near future for the patient or in the future for the patient. Why is that? Because it can quantify these changes and you can draw a conclusion from these changes and mix it up with your clinical judgment and the OCT findings to make a decision for your patient, whether he will go for some intervention or he will go for observation. Now, we have certain defects in the visual field. We have superior arcuate scotoma, we have paracentral scotoma, we have gyram scotoma. Some patients unfortunately present to you with a tunnel vision, which is a late stage. And in such a condition, we need really to counsel the patient carefully about his future potential for going for surgical intervention and the potential complications and loss of his visual acuity. As we used to mention to you before, and we mentioned today in the basic science course, that's the old Garwe-Heath map, which have been modified several times by several researchers. The importance of this Garwe-Heath map is that it will tell you while examining the patient clinically, where is the expected visual field change could happen in the future. For example, if the patient is having thinning in the red and yellow zone, the expected visual field change will be in these superior areas. If he's having thinning in the green zone, the corresponding visual field change will be in the inferior green zone, and so on. Again, the optic nerve head phenotypes are important to remember, the focal, diffuse, and sclerotic. And here we have an example of a patient who is having focal optic nerve head damage. He have lost inferior rim. And when you look at the Garwe-Heath map, the initial map or the mother map, you can see that the inferior thinning is actually corresponding to the reddish zone that the patient is having, and some is going toward the yellowish zone. And when you drop it on the visual field, you will see that the patient might have a hit zone superiorly, which is actually matching to the reality. So that's the importance of plotting, the expected visual field defect, where it could be in the future, so that you can act accordingly. Another example, a patient who is having visual field defect and he's having thinning inferiorly, but if you focus superiorly, there is thinning as well. And when you look at the areas of the expected hit in the future, in the yellowish and reddish zone compared with the superior areas, the bluish and the greenish zone, most of the hit will be corresponding to the greenish zone, which is inferiorly here, and some existed superiorly. Another example as well, showing you the significant thinning superiorly. You can look at these two large blood vessels laying exactly at the disc margin. And when you plot it on the mother map of Garwe-Heath, you can see that the changes are expected to happen in the bluish zone and some of the greenish zone. And that's exactly what's happening in the visual field. So you need to train yourself to adopt, these visual field maps and take the structural functional changes seriously, because it will help you in your glaucoma management and predicting the future changes. Usually, when you comment on a visual field, you will just wonder what happened exactly. You will ask yourself, what was done? Number one. Number two, you will ask about the accuracy. Is it a reliable visual field test or not? Then you will go to check if it's normal or not. You will check for the defect pattern. You will evaluate for compatible disease if it's glaucomatous, neuro-ophthalmological, or related to a retinal disease. Then you will review your recommendations again of being glaucomatous patient or not. So for example, when we come to this patient, we will go over what was done for the patient, and this is a CETA standard 24-2 test that was done for the patient. We want to make sure that the age is registered correctly, because the Humphrey Field Analyzer will simply compare the patient's database to a normative database. So if you put the age of a patient who's actually 70 and you register it as 35, of course, the machine will give you a result that the patient is having generalized depression, because there are difference in the retinal sensitivities of a 35 years old compared to 70 years old patient. You will go over the reliability indices. You will go for the fixation loss, and the fixation loss is simply the machine is throwing a stimulus over the blind spot, and the patient is not supposed to respond because it's the blind spot. If the patient responds, then that's a fixation loss. And fixation loss is allowed to 20, sometimes 30% if the patient is having advanced glaucomatous damage with enlarged blind spot. After that, you will go for the false positive and the false negative parts of the reliability indices. And the false positive will be high in case the patient is actually responding to noise, but not stimulus. When the patient is actually giving the light stimulus, it will give sound with it. Sometimes the patient will check, the machine will check if the patient is actually paying attention or not. So instead of having stimulus of light, he will have only sound or noise. So if the patient responds, so this is a false positive. On the other hand, if the patient responded in a previous area to a stimulus, and then you presented a brighter stimulus again, and he did not respond, that does not make sense. So the patient is having false negative response. You will need always to pay attention for the fovea here if it's on or off, because if you have a fovea which is on and it gives you a sensitivity of 35 or 30, and at the periphery of the retina, the patient is having more, threshold sensitivity of, let's say, 40, it doesn't make sense. And vice versa. If the patient is having low threshold sensitivity at the foveal area and better sensitivity in the adjacent areas, so the patient might have retinal diseases that cause these changes. After you finish from the W, what was done, and from making sure that this is the correct patient, correct name, correct ID, pupil diameter is more than 3 millimeter and is stable, not variable whenever you change the test from each visit to the other, and you check the reliability indices, then you will go to check or comment if this test is normal or not. What we see here in this gray scale, that the patient is having abnormal test. So now we admit that the patient is having normal test. We will go to the next stage. You will go for the defect. So the patient is having superior scotoma. You want to call it arcuate, it's fine. After that, you will evaluate for compatible disease. You will look for the optic nerve head damage here. And the patient is having focal optic nerve head damage affecting the inferior pole corresponding to the reddish zone, and you expect the patient to have these changes in the visual field, which are actually matching the reality. After that, you want to quantify these changes. How significant is these changes the patient having? So you will go for the mean deviation, and after that, you will go for the pattern standard deviation. So the mean deviation here is -3, and the pattern standard deviation is 7. So a mean deviation of -2 to less than -6, or -6 is actually mild, -6 to -12 is moderate, and more than -12 is severe glaucomatous optic nerve head damage. That's another visual field printout of a patient who is having significant glaucomatous visual field damage. Again, you need to apply the same principle. So we'll go for the W, Y, what was done. So what was done here is 24-2 CETA standard. Patient reliability indices should be reviewed again. Fixation loss and false positive and false negative should be less than 20%. With advanced disease, you can accept 30%. You will make sure that the fovea is on. You will make sure that the pupil diameter is 3 millimeter and not less than 3 millimeter. If it's less, then you need to check if the patient is having posterior synechiae with small pupil or not. Or if the pupil in this visit is of 3.5 millimeter and the next visit is 6 millimeters. So the patient might have a dilated pupil, which will affect his visual field results. So we go for the accuracy and the reliability indices. After that, we go for the N. So we finish the W, we finish the A, then we go for the N. Is it normal or not? And what appears here from the gray scale that you can use for your own interpretation and for the patient explanation and understanding that you have an abnormal defect superiorly that does not allow you to see your superior visual field. After that, we will go for the defect pattern. So the patient really is having a defect superiorly, which is very dense. Why is that? Because when you go for the total deviation map and move toward the pattern deviation map, which is the corrected map, the map in which we'll add for any other media opacity that could play a role in depressing the visual field like cataract, he's still having a dense superior scotoma. So the patient here is having dense superior scotoma, and when you look at the optic nerve head, he's having as well significant inferior disc damage. And when you go over the Garwe-Heath map or the mother map, you will look that this could correspond to the reddish zone changes, which is happening here in reality. And when you go to look for the mean deviation and the pattern standard deviation, the mean deviation is of -10 and the pattern standard deviation is of 12. So -10 is between 6 and 12. So this is moderate glaucomatous optic nerve head damage and showing us a moderate glaucomatous visual field changes or damage. Another example, a patient with glaucoma who presented to your clinic having this picture. We will use the same principle again. We will go with the W, what was done. It's a 24-2 CETA standard. And the patient is having the correct age entered, the correct ID number, the correct name, left eye because the blind spot is on your left side. And then you will go and check for the reliability indices, which are acceptable for the patient. You will go after that to check for the fovea, if it is on or off. And you will go and check if this gray scale represents a normal visual field or not. And the N goes for abnormal here. And after that, you will check for the defect pattern. So you can see that there is dense superior scotoma and there are some dense or some inferior scattered scotomas. When you look at the disc photo, you will see that the patient lost the superior rim and part of the inferior rim. And when you correlate it on the mother Garwe-Heath map, you will have a corresponding changes in the visual field test. Now, to quantify it or to comment on this visual field result, the patient is having -8 or -6 mean deviation changes, which is mild to moderate, and a pattern standard deviation of 6 to 8. Another example. So this patient is presented to you because of significant drop in vision. He cannot drive at night. And when you look here at his visual field, you can see that the patient is having diffuse optic nerve head damage from the clinical disc photo here that you can see. And when you go over the strategy that was used, it was 24-2 CETA standard. Again, you need to check the patient age. You need to check for the ID number. You need to check for the patient name. You need to go for the reliability indices, make sure that the patient did the test in a reliable way or not. Fixation loss is acceptable here in this condition. False positive is acceptable, false negative is acceptable, and the fovea is on. After that, you will go for the gray scale, and what you can see here is that the patient is having definitely abnormal visual field test going toward tunnel vision. So when you go to the total deviation and move toward the pattern deviation, yes, the pattern deviation corrected to some extent some of the changes, but still the patient is going toward tunnel vision. Now, when you go for the mean deviation and the pattern standard deviation, the mean deviation is -18 and the pattern standard deviation is 11. So in such condition, the mean deviation is exceeding the pattern standard deviation. So why is that? Because the mean deviation is telling us how significant did the patient's visual field departed from the normal. That's why he's having -18, which is severe glaucomatous visual field damage. The pattern standard deviation it shows us how significant particular areas in the visual field departed from normal compared to the other areas. And here you can see if the patient is having or is going to tunnel vision, all the areas are affected. That's why the pattern standard deviation is actually less, because the patient is having visual field changes all over, and not only in a single sector. Our last talk will be about UBM, or ultrasound biomicroscopy. Now, ultrasound uses in ophthalmology or in glaucoma are for two main things. Number one, to do a B scan, if you cannot see actually the posterior pole very well, or to assess what's happening beyond the cornea or beyond the iris. So in ultrasound, we can use 10 megahertz probe, and we have now new modalities that allow us for or give us different measurements. The depth of penetration can be 4 centimeter and the resolution of 940, but now we have much more better modalities. And the UBM can range between 35 and 80 megahertz. Depth of penetration is variable according to the hertz that you have. It can be 6, 4, and 2, but the resolution will vary accordingly. So with high penetration, you will have less resolution and vice versa. So if you have 80 megahertz UBM that you are using for glaucoma patients, it will be best for detecting the characters of the Schlemm canal. It can give you the diameter of the Schlemm canal, and it can give you clues about the wall of Schlemm canal if it's actually ruptured or not, especially in cases after apic or abexternal canaloplasty or abinternal canaloplasty. So the need of UBM is actually to show us structures anterior to the pars plana and posterior to the cornea. So it can give us good depth with high resolution. You can see some structures with UBM, like the corneal epithelium, stroma, endothelium, anterior chamber, and the lens as well. One of the most important landmarks in the UBM is the scleral spur. Why is that? Because from the scleral spur, you can take it from there and detect changes within the UBM, whether the patient is having synechia or angle recession or cleft and so on. So if you are using a UBM, which is 35 to 80 megahertz, you will have a scleral spur, which is showing you the area between a radio-opaque shadow of the sclera and relatively radiolucent shadow of the cornea. And what we mean by the scleral spur is the area laying in the middle here. That area is the cornea, and that's the sclera. Under it is the ciliary body. You have the posterior chamber, the lens capsule, and the lens. Again, you have the scleral spur, which is your important landmark. You have the sclera, cornea, anterior chamber, posterior chamber, ciliary body, lens capsule, and the lens. So the importance about UBM is that it can evaluate the angle for you. It can give you the anterior chamber depth estimate, posterior chamber depth estimate, corneal thickness, iris thickness, configuration and insertion, and the trabecular meshwork as well, ciliary body thickness, scleral thickness, IOL thickness, and but it cannot evaluate the lens thickness completely because of the penetration. So it gives you the gonioscopic feature in case of corneal edema or opacification. Now, we will show you some examples using the UBM or the ultrasound biomicroscopy. So that's a UBM of a patient in which he's having a flat iris plane, and that's the appearance of anterior bowing of the iris and narrowing of the angle, and that's a case that we call a patient with open angle and narrow approach. Again, a patient who is having pigment dispersion in which you have widely open angle and posterior iris bowing, and a patient who is having peripheral anterior synechia and iridocorneal adhesion. If you look at the scleral spur here and you look at the synechia, it's bypassing the area of the scleral spur. So that's a broad peripheral anterior synechia. It shows you a closed angle with anterior bowing of the iris and show you the angle which is opened after doing peripheral iridotomy. So you can see here the scleral spur, and you can see the significant narrowing of the angle, and you can see the scleral spur and the angle is open, and you can see here as well the opening that you created using your lag laser iridotomy on the iris structure using the UBM as well. You can see here a patient who's having plateau iris with anterior ciliary process, and you can see the plateau iris closing the angle, and you can see the opening of the angle of the plateau iris after performing argon laser iridoplasty. Again, a patient who is having a normal angle and a patient who is having angle recession. So what's the difference between both scans, both UBMs? If you can look here, that's the scleral spur, and that's the scleral spur, and you can see that there is posterior displacement of the iris scleral insertion. Look at the location here, and look at the recession here. So you created more space that resulted in widening of the ciliary body face with no disruption of the interface between the sclera and the ciliary body. Because if there is disruption and there is a communication between the supraciliary space and the anterior chamber, then we are having something called cleft. طيب. And that's the area of cyclodialysis cleft. So you have a direct communication between the supraciliary space. You can see the ciliary body here, and that's the supraciliary space, and the anterior chamber. And you can see here the scleral spur. Another UBM showing a patient who is having iridodialysis after trauma. So that's the normal angle configuration on UBM, and that's the iris disinserted from its roots, but does not cause any other harm. So that's iridodialysis. Sometimes in patients who are having spherophakia or microspherophakia, you might have zonular dialysis, which can be detected as well using UBM. So you can see here the spherical lens, and you can look at the disrupted zonules here. You can have ciliocoroidal effusion without the presence of cleft, and you can have also ciliocoroidal effusion and the presence of cleft. So what's the difference? You can see here that the ciliary body is edematous. However, there is no direct communication between the anterior chamber and the supraciliary space. You can see that there is separation of the ciliary body from the sclera because there is fluid accumulation. And you can see that there is translucent supraciliary fluid. However, still that there is no direct communication between the anterior chamber and the supraciliary space. So, edematous ciliary body, supraciliary fluid. So this is ciliocoroidal effusion, but there is no direct communication. If you have direct communication, then that's a cyclodialysis cleft. You can see a patient who is having PCIOL with open angle, and it shows you a highly reflective surface. And you can see the position of the optic and the haptic, and you can see that there is a large peripheral synechiae developing, and it's bypassing the area of the scleral spur. A case of aqueous misdirection. So you can see here the normal anatomy that you can detect using the UBM in normal eye, and you can compare it with cases of aqueous misdirection. So what are the differences? Number one, you can have or you can see extremely shallow anterior chamber. Number two, the angle is actually lost. It's completely closed. Number three, you have forward rotation of the ciliary body, and along with the forward rotation of ciliary body, you see sometimes fluid accumulation in the supraciliary space. Another case that shows you extremely shallow anterior chamber with closed angle and forward rotation of the ciliary body with presence of fluid in the supraciliary space. A third example. Some might argue, why should we use UBM and not anterior segment OCT, which is a valid argument. However, each diagnostic utility has its own indication and own benefits and own advantages. When you compare UBM with anterior segment OCT, UBM is a test that you need to do it after having a contact with the eye, opposite to anterior segment OCT. You need to do it in supine position or standing position sometimes, while the OCT in sitting position. You have a coupling agent in UBM, and in anterior segment OCT you don't. The axial resolution is 30 micron compared to 5 micron in OCT, and with advanced OCT devices you have much more better axial resolution. you have 60 micron lateral resolution compared with 15 micron lateral resolution. And with advanced technologies, this number can change significantly. So you might find a machine that has much more better resolution. We have 4 to 6 millimeter depth of penetration UBM compared with 1 millimeter depth of penetration. So what would you use to assess ciliary process? Would it be anterior segment OCT or UBM? So we'd go for UBM because of the more potential for penetration and assessment of the UBM. So patient in which you are suspecting that he might have aqueous misdirection or annular ciliocoroidal effusion. Doesn't make sense to use anterior segment OCT. So you need to go for UBM because it's the diagnostic utility that could help you to see the ciliary body and the forward rotation of the ciliary body. The UBM needs a skilled technician to show you the images and to interpret the images, and can give clear images in opaque cornea, the opposite to anterior segment OCT, in which it needs some experience, but it's an operator-friendly device that allow anybody who's have sufficient training to do it. We will give you here some examples of a UBM that was done for a patient post-trabeculotomy surgery and develop hypotony and shallow anterior chamber post-op. I hope that it will work. So I apologize, the video is not working here. So anyway, أيوه ممتاز شكرا. So that's a UBM of a patient that underwent trabeculotomy surgery and had hypotony and shallow anterior chamber post-op. So what happened here is that during the surgery, inadvertent cleft developed and resulted in direct communication between the anterior chamber and the supraciliary space. So that's why the patient developed hypotony and shallow anterior chamber after that. Again, this is another UBM imaging, show you the direct communication between the anterior chamber and the supraciliary space. So that's the direct communication. And that's the shallow chamber post trabeculotomy surgery. Another patient who underwent filtering surgery, developed pain and high intraocular pressure, and that's his UBM, showing you very shallow anterior chamber and forward rotation of the ciliary body, as you can see here, and closed angle. Another patient who underwent previous Schlimm canal surgery, and that's what you see here is an 80 megahertz UBM showing you the Schlimm canal. And that's the other Schlimm canal. You can see that there is an opening in the wall of the Schlimm canal. And that's because during canaloplasty, there was over distension of the canal while injecting or doing the viscodilation, which resulted in ruptured Schlimm canal. And with hypotony phase, there was egress of blood between the desmet and the stroma and resulted in hemorrhagic desmet membrane detachment. Our last case is a patient who is having pigmentary glaucoma. And as we mentioned before, you will have posterior bowing of the iris. And that's the flattening of the iris after doing YAG peripheral iridotomy to reverse the reverse pupillary block. Thank you very much for your attention.